Okay, a very good afternoon to all of you. Thanks for taking time off this Sunday evening to listen to us. As I'm pleased to be here. This is the third of our community talk series on health, or rather musculoskeletal related issues. We started out talking about low back pain, and then we spoke about shoulder pain. And today I'm here to speak about what is close to my heart. This is essentially my bread and butter that I see in the hospital on a day-to-day basis on knee pain, and what you need to know as a layperson on what certain symptoms or conditions might mean to you. So I have here with me Gareth as well. Very pleased to have him on board. He's been a keen collaborator for this community talk series from the start. He's a very skilled senior musculoskeletal therapist that I have had the pleasure of working with, and you'll hear from him shortly. So just a brief introduction. I'm a consultant orthopedic surgeon at Sengkang General Hospital and Singapore General Hospital. And my key surgical interest is in the hip and the knee. And I see patients across the age groups with knee and hip pain. And generally speaking, I try to save their knees from needing a knee replacement because we have more and more young people coming with arthritis of the knee, and a knee replacement isn't a great solution for someone that is young. And ideally, we want them to go on with many more active years with their own knees as long as possible. I do a fair amount of research in the same topic as well, in trying to seek out new solutions for knee arthritis. And as mentioned previously, Mr. Gareth, he's here today. He's a musculoskeletal therapist and a director at Heartland Rehab. While his special interest is in treating patients with low back and neck issues, I'm pretty sure due to the sheer volume of patients with knee problems in Singapore, he sees a fair amount of patients with hip and knee problems. So today I'm going to paint the picture very simply, so that it is easy for you to understand what knee pain really means and when you should be seeking medical help, right? So of course, there's lots to cover, but I'm going to make it really bite-sized so that you guys have something simple to chew on and take home with you today. And without further ado, let me begin. So I'm going to be speaking about just knee pain in general, and Gareth will of course be speaking about physical therapy that you guys can try on your own first before seeking medical attention if you are suffering from knee pain. So as with all things, I always like to begin with what is the knee joint itself, right? A lot of medical jargon here, not to worry. I'm going to be telling you in simple terms what each of these structures in the knee represent. As you know, the knee is made up of actually 4 different bones, right? The, the bone at the top is called the femur, that is your thigh bone. Okay, the bone at the bottom, the bigger one, is called the tibia, which is the shin bone. And of course, the smaller bone at the side called the fibula. These make up 3 bones, and of course, not to forget your kneecap itself, otherwise called as the patella. So all these 4 bones are what we call as the knee joint. And interestingly, the knee does not consist of just one main joint. There are actually sub-compartments in the knee joint. So when you say knee pain, there could be a problem with any one of these 3 different compartments in the knee. So on the inner part of your knee, so when you say inner part, that's what we call as medial, right? And on the outer aspect of the knee is where we say as lateral in terms of medical terms. So the inner compartment of the knee is known as the medial compartment. The lateral compartment is on the outside of the knee. And of course, we have the patella and the femur compartment, otherwise known as the patellofemoral compartment, or I simply just refer to it as the kneecap, the front of the kneecap compartment to my patients. So if you have knee pain, any of these 3 compartments, 1, 2, or even all 3 could be affected by conditions. And if you look at each compartment, there are structures there that could be injured. So if you look at the medial compartment, you can see this white structure. That is the most important structure in the knee. That is called your cartilage. So the cartilage is actually the cushion of the knee, the covering of the knee. And this is what takes most of the pressure when you walk. It composed of a lot of cells and water, and it has the capacity to compress itself like a sponge when you walk. And just like a sponge, when you walk, it releases fluid into the knee joint called synovial fluid. And that is why sometimes when you have certain knee injuries, you get a swelling because the cartilage gets injured and there's a lot of fluid being released by the cells. And then you have the meniscus, which is another important aspect of the knee joint. The meniscus converts a flat surface of the shin bone called the tibia into a cup-like rounded surface. As you can see, the top of the bone, the femur, is rounded. The bottom bone is flat. So if you have round on flat, it's going to put a lot of pressure, right? So God was very smart. I mean, he created a cup, a disc called the meniscus, which is a further shock absorber to the knee. So it converts the flat shape of the shin bone into a circular shape, like a cup that can receive the thigh bone on it, so that the joint itself is very congruent, and when you walk you feel that there's no resistance to walking. And this is the same in the outer compartment of the knee as well. So you have the cartilage and the meniscus. And of course, as with all joints in the body, you also have ligaments, right? They are very important ligaments. They stabilize the knee. If you had injured any of these ligaments, then you have a very wobbly knee, or in very severe arthritis, you may have shrinking of these ligaments. That is why you get bow-leggedness, or what we call knock knees, when your knees point to inwards or outwards, depending on which compartment is affected. So those are your medial collateral ligament on the inner side of the knee, your lateral collateral ligament, which is on the outer side of the knee, and inside the knee itself, you have what is called the cruciate ligament. Cruciate in Latin means cross. So you can see how these two ligaments are crossing. One is at the front, therefore it's called the anterior, which means in scientific terms means front, anterior cruciate ligament, and the one at the back, posterior means back, it's called the posterior cruciate ligament. These ligaments are more injured in sports injuries, but they are also involved in diseases like arthritis as well. So it is important for us to have an overview of the different things that can be involved in any of the condition that causes knee pain. Now, we just talking about bones, cartilage, and ligament now. There's a whole different structure above it called the muscles, right? So all these muscles are working hand in hand when you move your knee joint. And these are very large and strong, powerful muscles, right? At the front of your knee, on your thigh, you have your quadriceps muscle. You can see from the name, if you understand a little bit of Latin, quads means four, right? There are four different muscles at the front of your knee that is working for you to be able to stand straight and walk. At the back of the knee, you have your hamstring muscles. And at the back of your calf, you have two big muscles as well, called your gastrocnemius and your soleus muscles. Now, all these muscles are involved when you're walking. And of course, if your knee is arthritic and you start to get pain, these muscles have to work extra hard. And you may even get muscle soreness in your thigh, at the back of your knee, or the back of the calf. All these pains may be due to a knee problem. It may not just be a thigh problem itself, but it may give hint that you have a knee problem, and that's why these muscles are feeling tired. So now I'm coming to the anatomy of pain, right? So whenever you go to the doctor or you come and see me, I always ask you, where is your pain? This is because based on the location of your pain, we can sort of deduce where your problem might be. But having said that, sometimes in arthritis, your pain can be anywhere, but still we want to know what structures may be affected in your particular condition. So if you have pain at the front of the knee, it is usually due to the kneecap, the patella, as I told you. It could be arthritis, it could be inflammation of the tendon of the bone, or it could be a muscle ache that is causing you the pain. If you have pain at the back, usually at the back, it is due to arthritis. Fluid from the knee can often escape through the back and cause a swelling at the back called a Baker's cyst. So you may have noticed in your elderly parents or your own self, there's some swelling at the back of the knee, and that is due to the fluid accumulation at the back of the knee. And pain on the inside and the outside can be due to injuries to the meniscus, and this can be a sports injury or injury as a result of degeneration, which we see in arthritis. So it is very important to know where your pain is, because pain at different locations could mean different things. Again, what are the causes of knee pain? Firstly, you think of something within the knee, of course, right? Arthritis in the knee, a sports injury, a meniscus tear, all this can cause knee pain. But interestingly, things above the knee can also give rise to knee pain. For example, if you have hip arthritis, you can actually feel the pain in your knees as well, because there's a big nerve that connects the hip to the knee. So a hip problem can sometimes masquerade as a knee pain. And sometimes that's what happens in the clinic, where we examine your knee is fine, x-rays of the knees are fine, and we scratch our heads thinking, why are you having knee pain? And when we x-ray the hips, we see that you have hip arthritis. Interestingly, things in the back, low back, can also cause knee pain, because the L3 nerve, if you remember the lumbar spine, earlier we spoke to the different levels as L1 to L5. The nerve that comes out of L3 actually contributes to the sensation on the inner aspect of your knee. So sometimes spine problems that impinge on the L3 nerve, although not common, can also cause knee pain. So this is just a cautionary tale to tell you that not everything is in the knee. Sometimes knee pain could be due to a hip problem or even a spine problem. So it is important for you, if you have prolonged knee pain, to see a doctor and get yourself properly assessed. And this is what I'm going to talk about today, a focus on osteoarthritis. And what is osteoarthritis? It's a big word, but essentially it just means wearing down of a joint, right? Or wear and tear of a joint. You can see on the right side on the cartoon, you can see that the cartilage is eroded with multiple ulcers in the joint, and it involves all three compartments. Earlier, we spoke about the patellofemoral or the front of knee compartment, the lateral compartment or the outer compartment, and the medial compartment. So when all three compartments are involved, we call it tri-compartmental osteoarthritis. This is globally affecting all the cartilage in the knee joint. And this is what an X-ray of such a knee will look like. When there's no more space between the bones, it's bone rubbing on bone, and no doubt that this patient will be having lots of pain. And unfortunately, if someone has this degree of arthritis, they usually would need a total knee replacement to treat their symptoms. So what are the causes of osteoarthritis? I just want to quickly tell you guys, this is not going to be a lecture on arthritis itself. It's really just for you to know what can cause arthritis. I would like to explain the concept of what is primary osteoarthritis and what is secondary osteoarthritis. When we say primary, it means arthritis that happens on its own without something else causing it. And just like high blood pressure, you have primary hypertension or primary high blood pressure that it just happens. There's no reason for it to happen. It may be a result of aging, and without any cause. Or it could be a secondary high blood pressure when you have a kidney disease, for example, and that causes the high blood pressure. So when we talk about primary osteoarthritis, it is generally due to aging process, due to a mechanical problem where maybe if someone is overweight or not overweight, they may have born with natural alignment that causes more weight to go through one part of the knee. And this could be the causes of the arthritis. That means there wasn't anything else that we could find that could have contributed to your arthritis. Secondary osteoarthritis, though, is due to something else. Sportsmen, when they injure their knees, when they injure the ligaments in the knee or their meniscus, that can give rise to arthritis. You could fracture your knee, for example, and as a result of the fracture, develop arthritis. Or you could have things like gout, rheumatoid arthritis, or any other diseases that could affect the knee and cause osteoarthritis. So remember, if you do have some of the risk factors like obesity, previous injury to the knee, gout, you are at added risk of arthritis, and all the more you should pay attention to your symptoms and look after your knees. Otherwise, the run-of-the-mill 60% to 80% of the population has primary osteoarthritis, which is arthritis that just happens without an underlying reason. So how do we treat arthritis? I think this will be a very interesting slide for all you guys, and probably a lot of questions on this. How do I treat it? Well, as we say, prevention is always better than cure, and true enough, right? So for arthritis, if you want to prevent it from happening, is to lead an active lifestyle and to manage your weight. You do not want to stack on too many kilos. Every weight or every 1 kilo of weight that you put on generally means up to 2.7 to 3 times the force that has to go through the knee joint. So you can imagine if you lose a kilo or two, that actually causes a lot of pain relief as well for the knee joint. So that will be the first thing, to modify your risk factors. And of course, if that fails, then you see a doctor. The first thing we do is usually get an X-ray, examine you, and give you some simple painkillers to take, right? And this may be Panadol or something stronger to reduce the inflammation in your knee joint. And sometimes we give you rubs as well. And sometimes we have injections. And this is what I am researching on now, to look at whether we have any magic injections that we can inject into the knee to see if the inflammation can be treated and if the arthritis process can be reversed. We can leave some time for questions about these injections later on. I'm pretty sure you're interested to ask about the lubricating gel and all that. They used to be very popular, but a lot of studies have been done to show that it doesn't help to regrow the cartilage. It merely works as a lubricant to help your pain relief, but we do not expect the cartilage to grow. Recently, we have had some promise with what we call experimental autologous therapies. These are products that we take from your own blood. We take your blood, we spin it on a machine, and we are able to extract out growth factors. And these growth factors are known in the lab to reduce inflammation in the knee. And if we can catch you early enough, we can use these injections to hopefully try to reverse the process early on in the arthritis. But if you come with the x-ray that we showed earlier, where there's bone-on-bone arthritis, these injections will not work, which is why we need to proceed to knee replacement. And of course, if someone comes and is very young and we're worried that they might progress to arthritis, we might actually encourage them or advise them to go for surgery to do cartilage repair. When there's a very small ulcer, it is amenable to repair. When the ulcer becomes very big and the whole knee is involved in arthritis, we can't do that surgery anymore. I take a particular interest in surgery called osteotomy. Osteotomy is a realignment surgery. For someone young with arthritis, this realignment surgery will offload the compartment in the knee that has the arthritis to allow them to lead an active lifestyle still. We're talking about 30 to 50 years old coming with arthritis in one compartment of the knee. So what we do is, if they are bow-legged, we try to straighten up their knees by doing this surgery so that their body weight doesn't go through the part of the knee that is affected by the arthritis, and therefore allowing time for the cartilage in that compartment to heal and recover. Of course, if all else fails, these patients will be subjected to a total knee replacement. Why are we interested as a healthcare industry in arthritis? You can see the figures from the UK, because these problems are costing our country a lot of money. Young people, when they have arthritis, they are taking days away from work, and that affects our economy. And procedures such as knee replacement, it is being done more and more commonly, and this also is costing our country money. So we want more patients to stay away from knee replacements and hopefully stay clear of expensive procedures if you can, by treating their conditions early. So I'm going to go through some do's and don'ts for those of you who have experienced knee pain before handing the mic over to Gareth. So firstly, if you have knee pain, do take a rest. Take a break so that the knee has time to heal, firstly. And secondly, so that you can know whether this is a serious enough condition for you to see the doctor. If you're going to be pounding on and on and on and don't give your knee a break, you are never going to know whether it's going to heal. So it is important, when you have a sore knee, give it a break of 2 to 3 days and see if it gets better. If it does get better, good. You can carry on doing your things progressively again. If not, please see a doctor, get some basic x-rays and assessment done for yourself. Next thing, of course, when you take a rest, do not lie on the couch for too long, because you need to build up your muscles. One of the treatment for knee pain is to make your muscles around the knee strong. So I would advise any of you with knee pain to do low impact water workouts. My favorite exercise that I recommend for my patients is to tell them to go to chest level water, just jog underwater or just walk underwater. That gives you a good aerobic workout to keep your weight trim, and it's also a very low impact exercise for your knee. Remember not to overdo your impact exercises. Things like lunges and jumping has a lot of impact on the knee, and you'll risk having more pain if you continue to do those activities. Next one, simple. I mean, all of you all would have heard of the RICE treatment. If you do have a sore knee, you have some swelling, rest for a day or two, ice your knee to reduce the inflammation and the swelling, compress your knee joint. It gives you some comfort and prevents the fluid from reaccumulating again. And of course, elevate it so that the fluid, by nature of gravity, can be reabsorbed back into your heart. Next one, I think good equipment is extremely important. Even if you're going walking, get good anti-slip protective shoes. Choose a low heel shoe, something that a high arch if you have an arch support problem, and a sole that has a good grip on the floor. I think this is very important that a lot of us do not pay attention to. And of course, at home, keep it well lit and clear of mess so that you don't fall and injure yourself. Each time you fall, you may think it's nothing, but you're risking injuring certain aspects of your knee, like your meniscus, for example, or your collateral ligaments. And these injuries do have an effect on progressing your arthritis if you have one. And don't be shy to use a walking aid, especially for the more elderly ones in the room, right? As we age, our muscle tone decreases, our muscle power decreases, and we may be losing balance when we walk. We don't want to fall and get a hip fracture. And part of the treatment is to use a walking aid that can offload your joint and therefore giving you relief from your symptoms. It is best to speak to a therapist who can assist you with the best possible device for yourself. The height of the device is important, and whether you use a walking stick or a quad stick or a walking frame is really dependent on your strength and how you are walking at present moment in time. And of course, needless to say, watch your weight. It is easier said than done, but it is extremely important that you do not stack on too many kilos in a too short a time, because then there's a risk that your arthritis may be progressing. So therefore, watch what you eat. Even moderate weight loss can make it better. And I would generally recommend my patients to aim for a loss of about 1 to 2 kilos first, and to a maximum of 5 kilos over a 6-month period as a very modest goal of losing weight. And when you are going for your exercises and your walks, don't forget to stretch. Tight muscles are very common as we age, as the muscles take time to recover, right? So stretch your muscles and ensure that they are warmed up before you go for the walk, so that you prevent cramps as well as minor muscle injuries that may then stop you from doing the exercise that you need to. And ask your doctor or your physical therapist for a very simple stretching exercise, and I'm very sure Gareth later will be able to share with us some of these. And importantly, if you are already known to have arthritis, a repetitive movement such as climbing stairs can wear down your knees, especially climbing down, because the force on your kneecap joint, the patellofemoral joint, is immense when you go down the stairs. I generally give advice of taking the stairs up, because going up the stairs builds your muscles and puts less stress on your knee than going down the stairs. So take up walk the stairs and then take the elevator down as a general principle. And of course, lastly, you don't have to deal with your knee pain alone, right? That's why people like me are around. Come to us, speak with us. We will assess you to say which stage of arthritis you are in, or diagnose what your knee problem is and prescribe medication or recommend some other treatment modalities. So with that, I'm done. We will probably take questions later at the end once Gareth is done with his talk. So do note your questions down. We have a chat box for you to type any questions that you may have, and if you're afraid that you're going to forget it, just go ahead and type it in the chat box, and we'll be very happy to answer these questions later. Over to you, Gareth. Thank you very much, everyone.
Okay, hi. Thanks, Dr. Amit. Can all of you hear me? Can you just give a thumbs up? Okay. Okay, so my name is Gareth. I'm a principal physiotherapist at Heartland Rehab. I'm the director and co-founder of it. So I have 8 years of experience in this industry, and I do see a lot of clients with knee pain. So as Dr. Hamid rightly said, it is a growing issue in Singapore as we go towards the aging population, right? So it is a degenerative issue, as well as something that we foresee we'll have to treat more. So I'll just jump straight in. Some of the things that I want to run through first. So a few terminologies for us to be a bit clearer. So there are active structures in our body, so soft tissues. So we usually refer to the muscles as active structures, things that move and cause movement. Then there are the passive structures, which Dr. Hamid ran through as well, the bones. So you have your patella, your kneecap, you have your femur, which is your thigh bone, you have your tibia, which is your shin bone, and your fibula. You also have your ligaments and the meniscus, of course, in the knee. Okay, and then, so these are the two main structures that we look at when it comes to knee pain. Is it an active structure issue, or is it coming from the muscles or the nerves, or is it a passive structure issue? Is it coming from the bones that are worn down, a ligament tear, a meniscus tear that's causing the pain? Okay, so the next two terminologies that I want us to be a bit clear on is what is stretching and what is strengthening. Because I see a lot of people coming in, I teach a stretching exercise, and then they ask if after stretching will my leg get stronger. Okay, so stretching is actually bringing a joint to its maximum available range of motion, and then you sustain a hold. For example, my wrist, if I bring my wrist to the end of the range, okay, into a flexion, I'm actually stretching out my extensors. Okay, I'll hold it for say about 15 to 30 seconds. Okay, that is causing that stretch into the muscle. Okay, so same thing, if I do it the other way around, I'm stretching the bottom, the flexors. Okay, so stretching doesn't strengthen your muscles, it just elongates the muscle for a period of time. It also has that neural, or it trains the brain to know where the joint should be at and the length of the muscle it should be at. Okay, strengthening on the other hand increases the ability of a muscle, okay, to exert force. For example, biceps. Okay, if I carry a weight and I bend the biceps through, okay, my elbow through. So what's happening is my biceps is doing its work of bending the elbow, okay, with weight. It's able, the more I do it, okay, the more it's able to carry heavier weights over time. Okay, saying the same thing, with that, on that same idea, if I were to carry, let's say I go to grocery and I carry something heavy like 5 kg rice pack, okay, I'm not actively bending my elbow, okay, but if it's strong enough, it should be able to withhold that load. So we are talking about knee, we are talking about things like your quad strength, okay, your hamstring strength and your calf strength. Okay, so we're going to run through mainly two types of exercises to prevent this degeneration or prevent knee pain. Okay, so let's just jump in. We start with stretching first. Okay, so I'm going to teach 3 main stretches today. So the first one being the quadricep stretch. Okay, so the quadricep stretch is actually, the quadricep is located at the front of the thigh. Okay, and what we can do is just to stand and support. I always encourage people to support, means hold their free hand on something that's stable. Pull the other leg, okay, the heel of the other leg towards your buttock, as what you see in this picture here. Okay, hold the stretch for 30 seconds. There are studies out there to show that any stretch less than 10 seconds is not very effective. You're just stretching into the stretch reflex of the muscle tendons. It doesn't really have any lasting effect to the muscle length. Okay, so 30 seconds to 45 seconds would be good. 15 is the minimum. Okay, and then I usually advise my clients to do it 10 times a day. You split it up, meaning you can do 3 to 4 in the morning, 3 to 4 in the afternoon, and 3 to 4 in the evening, rather than doing all 10 in the day, and then the rest of the day you are stuck in a shortened position again. Okay, so some modifications, some of us might already have knee pain. Okay, one way to do it, if you can't go into this kind of range for your knee flexion, right, you can use a towel, hook it around your ankle so that your heel doesn't come up to your buttock area. It goes a little bit lower, so you can control the amount of flexion in the knee. Okay, so the main idea is just to feel that pull, gentle pull. Okay, for stretching, don't go for no pain, no gain. Okay, all you want to feel is just a slight stretch, a slight pulling into the muscle. Hold it there for 30 seconds. Over time, as you do it, you get more range, then you pull it closer. Okay, so this is the first stretching that we can do, quadricep stretch. The next thing that we can do is your hamstring stretch. So the hamstring is located at the back of your knee, okay, and it does flexion of your knee. Okay, so sitting over the edge of the chair, this is the safest, okay, easiest to do. You straighten your leg out, okay, keeping the heel on the floor, point your toes up. Okay, so this is where one advice that I always give, don't curve your back. So a lot of times, what a lot of people tend to do when they're doing this is that tend to curve their back. If you can see my video, I'm curving my back. So if you really want to feel that stretch in the hamstring, keep your back straight and lean forward. Okay, if you are at home and you want to try it, you can tell the difference. If you curve your back, you'll probably be able to touch your toes because you're actually using your lumbar flexion to get that range in, and you're not really stretching the hamstrings. Whereas if you actually keep your back straight and you lean your hip forward, you pull the hamstrings more just by nature of how the hamstrings are situated, where the insertion sites and the origin sites are. So keep your back straight and lean forward. Okay, don't need to touch your toes. The idea is just to feel the stretch in the back of your knee. Okay, that's good enough. Okay, so same thing, 30 seconds to 45 seconds, repeat it 10 times a day, split it up. Okay, and the last stretch that I want to share, okay, is the calf stretch. So the calf is made up of your gastrocnemius and your soleus, okay, but the simplest stretch to do, okay, would be your calf stretch, which would be what we see in this picture, and many people are familiar with this stretch. One thing that I want you all to take note of when you're doing this stretch is to make sure both feet are pointing at 12 o'clock. A lot of us, when we do this stretch, we tend to put our back feet away, pointing maybe towards 2 o'clock or 11 o'clock, depending on which leg you're doing. You point it out, the stretch doesn't get as much. Point it back in, 12 o'clock, you feel more stretch into the gastrocs. Okay, and do it against the wall. And what you can also just watch, if let's say your legs are close together and you don't feel the stretch, okay, just open it wider. Okay, try not to get your knees bent over your toes for too long. That increases the stress and the load over the knee. Okay, so stretching for your calf. So 3 main stretches: your quads, your hamstrings, and your calf. Okay. Okay, then we'll jump next into the strengthening. So same 3 muscle groups, your quadriceps, your hamstrings, and your calf. Okay, so first thing, it will be your isometric quadriceps strengthening. So how you do this is to put the leg that you want to strengthen behind. So if you look in this picture, he will be strengthening his left leg, the one behind. Okay, then you try to kick the leg out against the leg in front. The leg in front will block the back leg. Okay, so you hold it for 5 seconds, repeat it 10 times, do it 3 sets a day. So we need to understand that with pain, a lot of time isometric strengthening can help reduce pain as well, rather than putting a weight on your leg and bringing it through range when it's already hurting. So isometric meaning the muscle is activating, but there's no movement, there's no change in the length of the muscle. Okay, so if I would just do a live demo, I'm strengthening this leg, I'll put it behind, the leg, opposite leg will block it. So what I'm trying to do is I'm just trying to kick the leg that is stable. So I'm just trying to push it out, hold it for 5 counts, 1, 2, 3, 4, 5, and let go. So you're activating the quadriceps muscle. Okay, so this will be the easiest way to do it. Okay, of course, as you get stronger, as you get better, okay, you can put an ankle weight. Okay, you can hit the gym for a knee extension machine. Okay, so this, you can start off with this first. Okay, the next one will be hamstring strengthening. Okay, so you can do it like what the man in this picture is doing. Stand with your hands supporting on a stable surface. Okay, bend your knees for your towards your buttock. Hold it for 5 seconds. Do it 10 times, 3 sets a day. Okay, so when doing this, one thing to watch out for is that you don't bring the knee, okay, to the front too much. Okay, then you will just be actually engaging a lot of the hip flexors and not so much of your hamstrings to do the exercise. So just to show an example, okay, when you're doing it, okay, don't bring your knee up this way. Okay, not really working the hamstrings much. What you want to do is keep the knees together, bend the knees up this way. Okay, and then put it down, up. Hold it for 5 counts, 2, 3, 4, 5, and down. Okay, can? So that's one thing to look out for. It's a common compensation that people make when their hamstrings are not strong enough. Okay, the next thing that we can do, okay, is calf strengthening. Okay, so your calf is something like tiptoes. Okay, the reason why I show this picture, I'm sure some of you must be horrified. If you're not, please be. Okay, do not do it on a chair. Okay, do not do it on a chair. Okay, I see Dr. Hamid's face was like, okay, please do not do this on an unstable surface. Okay, I saw this picture on the internet. If you do it like that, you're probably going to come in with more than just a knee pain. Okay, okay, so get your hands supported on a stable structure. A chair is fine. Okay, bring your heel off the floor as high as you can go. Okay, hold it for 5 seconds at the end. Lower yourself down nice and slow. 10 times, 3 sets a day as well. Okay, one thing to look out for this in terms of compensation, a lot of times we allow our ankles to roll out. Okay, try to focus on pressing the big toe into the ground. That will get your gastrocs firing off more. Okay, so get your big toes pressing into the ground so that your ankles don't roll out. Okay, so that's for the calf strengthening. Okay, one other thing that we do work at strengthening, like what Dr. Hamid was mentioning, sometimes when the knee is feeling the pain, it may not be a knee issue. It might be a hip issue. Okay, and a lot of times we do see people with knee pain coming in with weak hips, and we solve the hip weakness, the knee pain goes away. Okay, so one simple glute exercise. So glutes is actually your muscles in the buttocks. Okay, so what you see here is the clamshell exercise. So you can lie on your side. Okay, keep your ankles together. Okay, then open up the knees apart from each other. This will work your glutes muscles. Okay, and one common compensation that you all should look out for when you're doing this is when you open up the knee. Okay, one thing that people like to do when their hips are weak is they tend to roll backwards. Means their body tends to roll backwards. Okay, try to keep your body aligned straight like this lady and not let it roll backwards. Then you'll feel the muscles in the glutes working well. Okay, hold it for 5 seconds, do it 10 times a day, 3 sets. Okay, next we'll just have a quick talk on 2 functional trainings that we can do. Okay, so the first one is sit to stand. Okay, I think was it last year or last year, HPB launched this amazing campaign talking about risk of 4 risks and your lower limb health. Okay, so can you do a sit to stand, single leg sit to stand, right? Okay, so find yourself a stable chair. Okay, sit to stand without using your hands. Of course, if you can't, use hands first. Okay, use your hands to push yourself off, let your legs engage and on your way up, and sit down nice and slow. I always see people stand up really nicely and then they just plump themselves into the chair. Okay, so we want both up and down, nice and slow, controlled movements. Okay, while you're doing this, just watch. The idea at the end of the day is not for you to push yourself up this way, but is to lean forward and nice and slowly push yourself up. Same thing, lean forward, lower yourself down nice and slow. Okay, one other thing to watch as well, I'm going to do it forward. Okay, watch your knees. Okay, as you stand up, if you notice that your knees are collapsing inwards, okay, that means that your hips are not engaging well. What I want you to make sure is that get your knees over your toes, keep it open, over your toes, neutral, and then you stand up. Same thing when you are going down, keep it over your toes and down. Don't let it collapse inwards, okay? Nice up and down for sit to stand. Very simple action, okay, but very useful for training both the quads and the hips. Okay, can? So 10 times, 3 sets a day, good enough. If your chair or the surface that you're sitting on is higher, it's going to be easier. If the chair you're sitting on is lower, it's going to be more difficult. So you can use that as well to progress your strengthening. Okay, and last but not least, balance. Balance is very important. A lot of times with people with knee pain, they come in, okay, they have very poor balance for a few reasons. Okay, so proprioception, weak, or the sense of how you are in space, okay, or just very weak in the knee. Okay, so tandem balance is one of the easiest way to train your balance. Heel to toe, okay, stand in a straight line, one hand near a stable surface, okay? So let go of the hand, try to balance yourself for 10 seconds, then you stop, repeat 10 seconds, 5 times, do 3 sets a day, and then switch legs. So the leg that is behind is where you put your weight into, and that's the leg that you're using to balance, okay? As you get better, of course, you can then go into a single leg balance, okay? But start with this first. Okay, so those are the few exercises. I just want to end off. Prevention is better than cure. Okay, so don't wait until you feel pain, then you start to do these exercises. So just 4 things for you to watch. Number 1, watch your weight. Okay, so as Dr. Hamid has shared, shedding extra kilos have shown to reduce pain and improve self-perceived quality of life in people with knee pain. So there are studies out there to show that when you start to lose at least 1 to 2 kg, okay, you start to feel the improvement in the knee pain, you start to feel better, you feel happier, okay? Number 2, watch your exercise. So progression is always key, okay? Exercising itself doesn't wear out your joint faster than normal, okay? Exercising is good. Even some people ask me, is running a marathon bad for your knee? Actually, if it's something that you've been doing progressively and you're maintaining doing your warm-ups, maintaining your muscle strength, okay? Research has shown, or X-ray research has shown that actually the knee doesn't wear out as what we think it would wear out. Okay, so over exercising is the culprit. You know, like especially during circuit breaker, where suddenly all of us have a lot of time, people start jumping into exercise and thinking that they are as fit as they were 20 years ago when they were in secondary school or in the army. That's when all the injuries come. They forget that their muscles are not ready for the load. Their joints have not been loaded at that intensity for such a long time. What we need is your muscles to go stronger, your body to get used to the loading so that it can take that load. A lot of times is maybe we haven't run for about half a year to a year. Then we decide, okay, let's go for a run, 10 km. That's when the pain comes. That's when the injury comes. Okay, so watch your exercise. Progression is always key. Okay, number 3, watch your pain. Okay, pain does not always equate to irreversible tissue damage. Okay, sometimes you have that pain there. Okay, don't wait. Okay, rest, as what Dr. Hamid has suggested, rest, and then if it doesn't go away, see a doctor. There can be treatment, it can be salvageable. Okay, don't just think that, oh, okay lah, pain. A lot of people I hear say, already, doesn't matter, already my body is breaking down. It's not true. Okay, as we get older, doesn't always mean that you live with pain. Okay, listen to your body, offload as necessary, rest when there's a need to rest. Okay, and the last thing that I can advise you, watch our social media page. Okay, so Heartland Rehab Singapore, we share almost every week on different conditions or management strategies that we have. So watch us on Facebook, go and catch our old videos that we have posted on, or even on Instagram. From time to time, we will share on different topics as well. So you can take note of it and follow us on Facebook as well. Okay, so these are the 4 things, and I hope the exercises are simple enough. Last but not least, if you do have pain, seek professional help, see a doctor, go and find Dr. Hamid, see your GP, or even come in to see a physio. Okay, if there's anything that is more serious than you can handle, we will refer you to a specialist immediately. Okay, so back over to you, Dr. Hamid.
Thank you very much, Gareth. That was very comprehensive yet very succinctly illustrated. Thank you very much. And also thanks for sharing your Instagram handle. So I think that will be very useful for our participants to go and look at your previous videos and prospectively also look for the videos that are coming down. So we open the floor. We have about 20 minutes to 6. It's a good time for Q&A. While you guys are gathering your thoughts, I think there's a question from Sandeep on the chat box. 1.5 months ago, you started feeling knee pain when you were running, not able to run after running 2 km, not severe, but last 2 weeks the pain has come down, but not fully. Now you're having light, mild knee pain after running about 3 kilometers. Do I need to refer to a doctor? Okay, Sandeep, it really depends on quite a few things actually, whether you had, I know we can take this discussion separately. Obviously, I'm not going to ask you to give me a whole history in a public platform, but just answering the basic principles. So for everybody's benefit, it really depends on whether you had a previous knee injury or not, and when exactly you get the pain. Is it only on running and other activities you do not get the pain, and where in the knee the pain is from, and what you've tried so far for the knee pain to be relieved. And of course, it always helps if I'm able to examine you and find out where exactly the pain is. But the good news is that your pain is getting better, and that you're only having light to mild knee pain when you're going back to your previous activity. So it could have been just a very minor injury to either the muscle surrounding the joint, or perhaps you may have some minor wear and tear in your knee joint that is acting up. And it usually does settle down, with rest. So you've done a good thing by resting, and I think you can continue to progressively go back to your exercises. And if your knee pain does recur, then I think you should see a doctor at least for a proper assessment and get a basic x-ray if you hadn't had one done so recently, to know the state of your knees. And of course, it really depends also on your age and how much you've been running, your mileage, and in fact how this pain affects your day-to-day life as well as your work. That is important in our assessment. Gareth, anything to add to Sandeep's question? It seems to be reproducible after about 2 kilometers, so definitely activity related and sounds mechanical.
Yeah, I think you probably would benefit from perhaps coming in to see a physio just to check on like the muscle tightness, the muscle length. Maybe you try some of the exercises that I've shown you, and then try the stretches and pre-run. Make sure you do your warm-ups. Okay, so warm-ups and stretchings are different. Okay, so go and take a look at. I just did a talk on running and some advice for runners: passive stretches versus active warm-ups. So yeah, try some warm-ups before your run and see if it feels better and you can go further. But don't push through. If you feel the pain, stop and really go and seek some help. Yeah.
Okay, we have another question from Mona. Do we see a GP or what sort of doctor? It's a good question. I think when we talk about knee pain, it is a very common condition, and The first stop usually is the primary care. And when we talk about primary care, it is essentially GPs or your polyclinic doctors, or even I would say physiotherapists probably come under primary care as well, because simple things can be treated in an outpatient setting by our primary care professionals. So I would say go and see a GP or polyclinic doctor. They will do a basic level of assessment for you, which includes speaking with you, taking your history, examining your knee. And nowadays, most of our polyclinics are equipped with X-ray facilities as well, and they will do a basic X-ray for you. Only if they find that your pain has not improved with what we call standard treatment, which is essentially a consistent therapy for 6 to 12 weeks, some painkillers to treat the pain, and if it does recur again, only then would they refer you to a specialist. So yes, Mona, the answer to your question would be to see a GP and or a polyclinic doctor first for initial assessment, and then to be referred to a specialist if that's the first time you're having knee pain. However, if you've already been known to have a knee condition, for example, you are known to the specialist with having knee arthritis, and you've been discharged because it hadn't bothered you for a while and now you're having pain, you would need to see a specialist again. But in Singapore, as we know, we can't just walk in to see a specialist, otherwise you'll be charged private rates. So even in that situation, it would be the same thing. Go and see a polyclinic doctor, but do explain to them that you have been seen by a specialist before, so that they don't put you through the same run of conservative treatment for 3 to 6 months before they refer you to the specialist, that they will assess you as a patient that has already been seen by a specialist, and perhaps they will expedite the referral for you as well. I hope that answers your question, Mona. Okay, another question, will calcium deficiency cause any knee pain? Okay, that's an interesting question. Now, when we talk about calcium deficiency itself, it is we cannot just say whether it causes a symptom, right? We need to put some context to it. So when we talk about calcium deficiency, more often than not, I think you're referring to bone health and alluding to whether if you have osteoarthritis, for example, or osteoporosis, I mean, whether that will cause knee pain. In fact, there has been relationship shown between osteoporosis and degeneration of any joint in the body for that matter, because the bone forms part of your joint, and any metabolism of the bone that is affected will invariably affect the joints to a certain extent. But it doesn't mean that just because you have a calcium deficiency or osteoporosis, you will definitely get arthritis or osteoarthritis, but you can have what is called micro fractures, right? You can have small little propagation of fractures within the bone itself. And if these fractures are as part of your knee joint, for example, then yes, you can get knee pain, right? If the bone around your knee is the one that is weak and has osteoporosis, then you might have small cracks appearing in the bone structure around the knee joint. And when you put weight through the knee, then that can cause you pain. But calcium deficiency itself, in its own, we can't just relate it to any symptoms that way. Yeah. So I hope that answers your question, Sandeep. So if you talk about osteoporosis, then it depends. There has been correlation shown. And like I said, if you have micro fractures that are happening around a joint, you can get pain. And yes, I was just waiting for this question. Does glucosamine help to reduce pain? So glucosamine has been around for a couple of decades now, right? When it first was released by the drug companies, it was touted as a wonder drug that is now in the market to try to cure arthritis, right? Because what is glucosamine is essentially a building block of cartilage. So cartilage consists of many different cells as well as proteins and chemicals. And glucosamine is but a very tiny bit of that structure of cartilage. So what it does is it is supposed to be replacing the material that is worn out in the cartilage. And in doing so, it was supposed to, or it was thought of as a way to repair your cartilage that is worn out. But unfortunately, what works in the lab often doesn't work in the human body, and that's how complex we are, unfortunately. Glucosamine has been shown in recent times to be not any better than Panadol in treating pain in arthritis. So it is definitely not shown to help to regrow cartilage in the knee. But yes, if your question is, does it help to reduce pain? It is as effective as paracetamol. So that's the scientific answer to it. So in a day-to-day practice, I do not actively prescribe glucosamine. But if patients ask me whether they can glucosamine, my answer to that would be, you can try taking glucosamine. If it helps to relieve the pain, then it works the same way as Panadol would. And if you'd rather take glucosamine rather than Panadol for pain relief, then go ahead and take it. But if it is shown not to help your pain, then please stop it, because you're just burning your money in buying these supplements. They often can be quite expensive, because some companies just brand it differently, and they sell it for a premium. Gareth's contact details, yes, sure, Gareth, please put it up on the chat if you can, for everyone's reference. Is it necessary to go for a bone density test if you're having knee pain? Okay, so when we talk about osteoporosis, that is what we do a bone density test for. Then we don't really have knee pain as one of the criteria to go for osteoporosis, for osteoporosis screening, because a bone density test is a screening modality for osteoporosis, and knee pain isn't one of the criteria. Later, I will post a link on this chat group. It is a universally accepted questionnaire. Just takes 3 minutes of your time for you to fill up to see your risk of osteoporosis. And that app or that questionnaire will tell you what your risk is and whether you should be going for a bone mineral density, right? This has been a validated questionnaire across the world. It takes into consideration your age, whether your parents have had osteoporosis, whether you have any other risk factors for osteoporosis, and will tell you your 10-year risk of getting a fracture. So when we talk about osteoporosis, we are worried about you getting fractures due to weak bones rather than knee pain per se, as I mentioned previously. So the short answer to the question is no, it is not necessary to go for bone density test. If you're having knee pain, you should take my advice as I given previously in terms of monitoring your knee pain, taking rest, and seeing whether it recurs. If it does recur, see a doctor, get it assessed, get an x-ray, see someone like Gareth who can help you with exercises as a first stage in treating your knee pain. Gareth, we want to chime in. Do you have patients coming to you and asking you about like bone density tests and osteoporosis being a problem? Yeah, maybe you can add your piece as well while I try to get the link for the questionnaire.
Yeah. So we do have people like asking like, is it because they have osteoporosis or things like that? And actually, in fact, a lot of times if you do have osteoporosis and it is causing pain, the solution to osteoporosis is actually exercise. It's actually progressively loading the bone so that the body knows to deliver calcium to the area where it's needed. Yeah, so actually there are programs out there for osteoporosis where we really progressively keep loading you so that the bone density increases and that helps with the osteoporosis itself. So a lot of times we try not to link everything. The knee pain can be because of the microfractures like Dr. Hamid says, and that needs to be picked up by the x-rays. But the knee pain could also be just due to the fact that you haven't been moving, okay, and excuse me, and your knee is weak, the muscles are tight, which is causing the pain. And a lot of times you just solve that tightness or that weakness in the muscle, the pain goes away. And then with that loading, it concurrently also helps with the osteoporosis. Yeah, so that's what I encounter.
Yeah, that's great advice, Gareth. I forgot to mention about the weight-bearing exercises being very important as a treatment modality for osteoporosis. So great we touched on it. Next question is a very good and interesting question about PRP and whether it relieves pain and how long it will last. So let me just give a very short introduction to what PRP is. It falls into this bracket called autobiologics. It's a biological treatment that is aimed at reducing inflammation. So it is not just for osteoporosis itself. It helps with healing of tendon injuries, muscle injuries, and soft tissue healing. And there are other aspects of these injections as well. PRP is about one treatment modality. Other things include what we call autologous protein solution, which actually is similar to PRP technology, but a little bit more advanced in concentrating the growth factors. And of course, we have stem cell treatment on the other end that is not available in Singapore at the present moment due to the controversies and the potential for abuse, obviously. So PRP, for those who don't know, it stands for platelet-rich plasma. And APS stands for autologous protein solution. And these are essentially autologous because we take it from your own body. So what we do is we draw your blood, And companies have come up with these systems called centrifuge machines. We pour your blood into this centrifuge machine and we spin it for about 15 to 20 minutes. And the spinning action actually concentrates certain cells in your old blood called essentially platelets and platelet growth factors. So these growth factors are actually produced in response to inflammation. Osteoarthritis has a large component of inflammation. So your body naturally will try to produce anti-inflammatory proteins, try to heal your pain. And so by concentrating these proteins, we can then inject it back into the knee in hope that it will reverse the inflammation associated with the arthritis, and in doing so, relieve your pain. It sounds very straightforward and like magic dust, but unfortunately, there's still so much for us as clinicians, as surgeons and scientists to understand when does the vicious cycle can be reversed, or when does it go on to produce severe arthritis. We do not know whether it's only in early arthritis or in late arthritis. And we do not know how many cycles of PRP your knee needs. You can't expect to get one shot and that's it. It just doesn't work that way, unfortunately. And we can't get someone into a clinic to give them weekly injections of PRP either. So there are a lot of missing links in this chain that we are still finding out, and I'm actually personally finding out through research. But yes, PRP can relieve pain, but it is unpredictable. It shows, most studies show that up to 2 years, most patients with arthritis, at least grade 1 to 3 arthritis, which means not bone and bone, they get relief of their pain symptoms at the end of 2 years, and some studies even at the end of 5 years. But no study has been able to prove that there is regrowth of cartilage in the knee, right? It relieves your pain, and many other things relieve pain as well. Coming to TCM, someone asked about TCM. TCM relieves pain as well. So does exercise, so does losing weight, so does taking paracetamol, so does taking Ponstan and Acoxia. So all are actually targeted at pain relief. But the essence of PRP, the intent is for it to actually heal the cartilage, but we haven't actually had conclusive evidence that it can heal cartilage in someone with arthritis. So that's where we are with PRP. Hope that answers your question. Someone has asked an administrative question. Jonathan, this is for you. Do we get a certificate at the end of the webinar? I'm certain that me and Gareth don't get any certificates, but for the participants, John and Mona, I don't think we have been giving certificates for participants. This is supposed to be an educational webinar, but if you do require some documentation, they have attended this for some reason, you can chat with the organizers about that. Jane has a good question. Is knee replacement the last resort, and what is the cause and side effects? Is it the last resort? Yes, it is. Because it is essentially, if you looked at my slide earlier, it is essentially the top of the food chain, right? It is the last thing that we often offer patients when they have exhausted all other options. They have tried therapy, they've tried painkillers, and now their life is so miserable that without a knee replacement, they have to perhaps not be able to walk, or they have to rely on painkillers every day, and the quality of life is just not there. Therefore, like I said, a knee replacement is actually a lifestyle choice that patients make, because their arthritis is so severe that it affects their functional status, that they're not able to do the day-to-day activities, and therefore they choose to go for a knee replacement to make their life better. So it is often not emergency surgery that you need to go for. It is not a life-saving surgery. It is a decision that is made purely on these grounds of wanting to have a better function and pain relief, obviously. To me, I would like the patient to have gone through the process of exploring all the non-invasive options if it is suitable for them. When I say why I mentioned it's suitable for them, when you are 78 years old and you're coming with bone-on-bone arthritis, I am not going to recommend that you go through the entire array of treatment modalities, because I know that it is not going to work, perhaps because you're already bone-on-bone. Injection therapy and all that isn't going to work unless you're not keen for knee replacement. So for that person, I might consider accelerating the decision-making process for a knee replacement. But if you're 45 and you're coming with knee arthritis, I am not going to make knee replacement surgery even an option for you, because it is just too young to put a knee replacement in you, because you're going to come back 10 years later because you're so active, needing a replacement for the replacement I've put in. So for that patient, I'm going to try very hard for me to save that knee, to ensure that they are strict with their weight loss, that they've tried therapy, and I will see if they're candidates for biologic treatment in terms of the injections to try to save their knee, and even do other forms of surgery like osteotomy or cartilage repair for them to try to save the knee. So I'm a bit mindful of time, so perhaps we can take one more question. Okay, Mona, thanks for answering that question about certificates. Shuhaila has one question for us. I'm in my late 20s and I'm on my feet most of the time at work. My knee cracks a lot during the course of my day. Is it something I should be concerned about? I think this is a good one for Gareth. Pretty sure a lot of your patients ask you about crepitus and sound in the knee. So why don't you take that one, and I'll just end off by giving my input into that as well.
Okay, yeah, it's a common question, like my knee cracks or my elbow cracks or my shoulder cracks. So the cracking sound that doesn't mean that it's injured. Okay, so the cracking sound could be a tendon rubbing against a bone, or could be just be cavitation of the joints where there's a sudden change in pressure and the sound that gives a crack sound. In fact, there are research papers out there to show that if your joints can crack, it's still healthy. Yeah, so if it can crack, it can cavitate, it's still healthy. So there's nothing much to worry about unless with every crack you feel pain. If every time it cracks, you feel pain, something is wrong. Then you need to be concerned and you need to find out what's happening. Is there an inflammation? Is there like a tendon that is being irritated with your knee movement? Yeah, so the main thing is don't be too worried about the sound. But if there is pain or if there is like sudden swelling with the cracking, that's where we need to do more investigation into it. What's causing it? Is it a tight muscle? Is it something else? Is something wearing out? You do need an X-ray? Do you need an MRI on it? Yeah, so that's what we usually do, and we have help to reduce cracking in the knee, the sound of the cracking with, say, stabilization exercises. Sometimes it's just the patella not moving well, or the knee joint because of a hip weakness is not moving well. It causes that crack. When we kind of like get that stabilization back, then the crack goes lesser, softer, and not as irritating to the client. Yeah, so there's so many factors to it, but if it doesn't cause pain, there's no swelling, don't be too worried about it. Try some simple stretches for your muscles, some strengthening, and see if it works for you. Yeah.
Yeah, so Gareth is absolutely right. So crepitus without pain is not much of a concern, and it generally shows there's good lubrication in your joint. There's good movement between the two bones, so wouldn't be too concerned about it. And the rest of what Gareth says applies. I just remembered I haven't fully answered Jane's question. Cost of knee replacement. Generally speaking, in the government hospitals, it really depends on your subsidy levels that you're going for in terms of the absolute cost of it. So it's a bit difficult for me to answer that in an open platform like that, unless I have further details. And as with side effects, any surgery has side effects, and these can be broken down into side effects due to anesthesia, which is often affects the heart, brain, and often obviously unexplained death. Sometimes very, very rare, but it is one of the things that we often tell patients about. And the most important side effect you need to know probably about knee replacements is infection. It is thankfully very rare, but if infection comes on board, then obviously the benefits of the knee replacement are immediately lost, because you won't be able to walk on it well. With infection on board, you will need multiple surgeries to clean an infection. But like I said, thankfully it remains very rare. Other side effects, again, are rare: injury to blood vessels and nerves and things like that. Often these are surgical, technical aspects of the surgery that we often take very much care on when we operate on patients. And of course, there's always a 15% chance that your knee replacement might not go as planned, that you have continued symptoms and pain even after replacing the knee. And this is across the board globally, not just peculiar to Singapore. There's always that 15% of patients that do not feel satisfied after knee replacement. And the reason or the percentage of dissatisfaction increases with younger age. That we know for a fact. The younger you are and you go for knee replacement, the more unpredictable the outcomes are, and the higher the chance that you might end up being dissatisfied. And that is the prime reason why I am searching for other solutions for patients who are younger with knee arthritis. As long as you're above 75, you are the ideal candidate for knee replacement, because the outcomes in this age group is the best. But anyone less than 75, you have a 3 times higher risk of needing another surgery on top of your knee replacements. Quickly answering, TED stockings for relieving pain, no. TED stockings are called thromboembolic deterrent stockings. They are meant to reduce blood clots in the leg. They are not for arthritis, but if you have pain in the calves due to a vein problem, then these stockings will help to relieve that sort of pain, but not for knee arthritis. And last question for today from Sahara Jahan again. Gareth, perhaps it's for you. Been doing physio exercises after being referred by a poly doctor, but you feel more pain. Yes, absolutely common thing that patients tell me. I refer them to physio, and after a couple of weeks, they email me or they come to the hospital, say, "Hey, what lah, doctor? You refer me to physio. My knee pain is now worse." Extremely common. Great question for you, Gareth, to tackle.
Yeah. So I think we in the sense of pain after each session. I don't know what's the problem that you have. It could be a tendon problem, a knee joint problem, a muscle problem. So depends on what the issue is. If it is a tendon problem, a lot of times we do tell patients you exercise and you have a 3 to 4 out of 10 kind of pain. That's normal because tendons like to be loaded, and we are okay with that kind of pain score. If the pain is getting progressively worse with each session and the therapist doesn't change the intensity or the type of exercise, then perhaps you can feedback that there might be some other part that the therapist might have missed out, and you can bring it up to the therapist, tell them that there's that pain, and get them to modify the exercises such that it suits your level of functionality in the sense of strength of muscle and the strength of the sense of the availability of the joint of range of motion for your joint. So I would think that if there's pain after each session and it doesn't go away, it's progressively getting worse, do feedback to the physio as well as the doctor, so that there can be some modifications made. You don't have to suffer in pain. I always say that physio is always a team effort. It isn't just the physio giving you the magic solution. You go home, you do it, you feel better. A lot of times it's a team effort. You do your exercises, you give me feedback. Oh, I do this, I feel worse. I do that, I feel better. It gives me a better sensing of what are the structures that might be affected or might be responding better. I will work around it. And of course, then when I talk to the doctors about it, you talk to the doctors about it, there's that constant communication between the team. The main goal is to get you up and going, trying to avoid surgery and getting a better quality of life. So yeah, do feedback to your physio that you are seeing, that you're feeling pain after every session, and see if the physio can help you to modify the activities that you are doing. Okay.
Absolutely. So just to end that off, that sometimes we don't get everything correct as doctors, right? Sometimes there may be a diagnostic problem where perhaps yes you have arthritis, but you also maybe have a more severe, like you can have this thing called pes anserinus bursitis, where you have a swelling of a tissue right at the front inner part of your knee, and sometimes physiotherapy can worsen that, and all you might need is just a shot of steroids over the area to suppress the inflammation. You can get on with physiotherapy. So yeah, absolutely important to give feedback to your doctor and let the professionals have a discussion to forward you and progress your plan. So thank you everyone. You guys have patiently stayed till the end of the session. We are very happy to have answered all your questions, hopefully, and I've left my email address and Gareth's email address on the chat group if you have anything personal or further to ask us. And I'm pretty sure with the organizing committee, we'll be back again for another session with another topic of interest to all of you. Have a great evening, and have a great week ahead at work, everyone. Thank you.
Thank you, everyone. Thanks, Dr. Amit.